Welcome to Health Policy Off Script, the show where we step outside the talking points and dive into real, unvarnished truths about Canada's health system. If you are tired of crisis headlines, recycled solutions that are rarely implemented, and watching reforms stall again and again, you're in the right place. Here's the reality. Canada's health system is at a breaking point. We all know it, we all feel it. And somehow, despite decades of reports, recommendations, and roundtables, we still can't seem to make the changes everyone agrees we need to make. We know the problems, often we know the solutions, and yet we struggle to act. In this series, we're going off script to unpack the forces that keep health reform stuck, from political inertia to outdated policy processes, to misaligned priorities, to the uncomfortable questions. We'll explore where policy is failing, why it matters, and what it will take to set real priorities.
Your hosts for this series are three of Canada's most critically informed health policy voices. Let's take a moment and introduce them. Dale McMurchy is a health policy strategist and researcher from Ontario with a focus on primary care, chronic disease, and mental health. Ivy Bourgeault, originally from Saskatchewan and now in Ontario, with an international reputation on health workforce, focusing on gender and equity, reshaping how our health system runs. And Stephen Lewis, also from Saskatchewan, now calling British Columbia home, a leading voice in health policy, governance, and political dynamics that shape our health system. Together, our three hosts will be leading you through fearless conversations with our system leaders, no sugarcoating, just the truth, with realistic paths forward. So sit back, relax, and enjoy the series, whether you're at home, on your commute, or at work. This is a new space for clarity, courage, and action. This is Health Policy Off Script. Let's get started. Ivy, I guess the simple first question is, why are we here? Why a podcast?
Thanks, Matt. So I think the way that this started was not necessarily that we were going to do a podcast. I listened to a talk from Stephen and was very moved by that talk. And so followed up and sort of expressed to him my frustration. Well, how do we move on what you have just energized us about? And that is sort of where we started with these conversations. And so we wanted to move from talk to action. We appreciate the irony that we have a podcast where we are talking about that, but we are hoping to move others to action. So that was really where we began.
Like Ivy, I appreciate the irony too, that talking is the problem and we're proposing some kind of talking to be the solution. And I think what we agreed on pretty quickly was it has to be a different kind of conversation, hence the unscripted part. I suppose if I were to summarize, it would be, can we consolidate and get the truths that come from conversations in bars at conferences or in leadership circles when nobody's listening? Because there are truths out there. It's just that they don't seem to make it to the official version. So in a way, I think we miscast in some ways for public consumption what the problems might be. And I think that impedes us getting closer to what the solutions might be.
We've all had these conversations at work, sidebars at conferences, over dinner with friends. And much of it's belly aching, but we may think that we've got this great insight into what's wrong or what we should change. But seldom do these ideas come to fruition. So over the last year or so, Ivy, Stephen, and I have been belly aching or had great insight. I'm not sure what. But I think that what we really want to do is bring these sidebars to, air them and be frank and ask hard questions.
Many of our listeners will know who you are, whether or not that's in passing or have an intimate relationship, or many of our listeners will not know who you are. Beyond your bios, what drew each of you into health policy in the first place? What sort of motivates you to stay within the health policy space? And because we're kind of going off script here, what is something that people might not know about you and might find interesting to learn about you?
So my work in health policy started in Southern Africa, where I lived for about a decade. And in Lesotho, I worked in education and agriculture, but was drawn to health policy. And that's where I've landed. And I work for volunteer agencies, WHO, Canadian CETA. And then 2 weeks after Mandela was elected in 1994, I started working at the University of Cape Town. And it was an exciting time to be there with so much change. And one of the projects that I worked on was supporting an attempt to move to a primary healthcare system. And one project entailed assessing hospitals' efficiency in order to cut their budgets by 13% and then reallocate funds. And then with results in hand, off we went and talked to government officials. And then I experienced real-time policy development and implementation. So I saw what can be done in terms of transformational change, including in resource-poor countries where there's a real motivation and the wherewithal to make change, even under challenging circumstances. So when I came back to Canada, pretty soon I was disappointed by the schism between evidence creation and policy making, and the pace of change, and that we weren't doing enough with the resources and expertise that we have here. So I've continued to feel that frustration over the course of my career, and now I've decided to kick up a bit of dirt.
Well, my long ago training was in mainly political philosophy, and I ended up in healthcare by accident. It was the sort of most interesting job interview I had when I was finishing school, was with the then research and planning branch of Saskatchewan Health. And in a nutshell, it turned out that training in political theory, which is about justice, fairness, who gets what, and what the arguments are, is a pretty good foundation for what goes on in a public health system, because it is inevitably political, and I would argue it is rightly political. This is a public domain, and how it's organized, how it's delivered, how it's funded, and whose needs get met first, these are fundamentally important political questions. So despite the frustrations in making a better system, and I think arguably Canada's system lags behind its rich OECD counterparts in performance, it has two things going for it. First of all, it has a lot of talented people working in it, and they're just inherently interesting. And secondly, it really makes you think. I mean, healthcare systems are probably the most complex systems of any industry in the world, and to get them right is a constant challenge. So to me, the interest level and the ability to interact with a whole lot of smart people outweighs for me the frustrations of seeing change that's a little too slow and a little too late.
So, Ivy, you said you grew up on a farm where the simple rule is get it done.
Yeah, well, I think a lot of people now know that I've grown up on a farm. So I was born in the birthplace of Medicare in Saskatchewan, moved to Alberta, in the small town, Manville, Alberta, that Irving Goffman was born, very famous medical sociologist. So I feel that I have been an accidental sociologist thrust into, examining issues from a sociological lens on health and healthcare issues. And yes, I think growing up on a farm, that's very much part of your formative, is just focusing really on pragmatic things, getting things done, and working together. That's the other thing that's really important about, working together on a farm. Everybody has their component, and you recognize that everybody plays a role. And so those would be things: being an accidental sociologist in the healthcare field and bringing this rural upbringing to the table.
So we have lots of themes that we've talked about, lots of themes that we've discussed and that we're preparing for. Is there any specific one that each of you are looking forward to? What excites you? And what maybe is sort of overdue for an honest conversation?
I would say the overarching issue for me, first among equals, is accountability. I think we have a system that is very cleverly designed to avoid clear accountability for why we don't perform the way we should. We often have fairly damning reports. I mean, there was the famous Baker Norton report now 20 some years ago about the number of avoidable deaths in Canadian hospitals. The system just wasn't very safe. And then there's been a recent update that suggests not much has changed. And yet nobody really is held accountable for this. It's quite baffling. And the corollary of that is, how do you energize the public to pay more attention to the performance of the system. And again, I would summarize that by saying, I hope what this podcast contributes to is changing the story a little bit. We have an official or quasi-official and widely accepted version of what the problem is, and it's usually scarcity. We don't have enough doctors, we don't have enough money, we don't have enough machinery. And I think, and a whole lot of very intelligent analysts of the system would say, actually, that isn't the problem. So paired to accountability is, whose story do you believe? And I hope this podcast gets out into the public domain what the alternative versions of that story are.
I'm looking forward to really understanding how do we follow through on all the recommendations that have been made. Who is going to lead? Who is going to take those on? So we really want to have conversations that empower people to work together, but to lead from where they are and take hold of some of the recommendations. And so that's the kind of conversation that I'm hoping to have, to instigate and put some fire in people's bellies to say, yes, we have to move from where we are. Somebody has to do something and not wait for somebody else to do that. I'm going to do something within my realm, and I'm going to talk to somebody else about how do we move this forward. Like really important coalitions. But for me, the lack of follow through is enormously frustrating. And I don't want to have a recycled conversation, as you noted from the outset. I really want to have conversations about how can we help people, empower people to move and follow through.
Just to reiterate what Stephen and Ivy said, it's inconceivable that our system is not in any way accountable for what's delivered and how. And it is, frustrating that we haven't achieved what the potential is, because the promise and the potential are really there. But the number of iterations of reform that I've seen is dizzying. The thing that's the most frustrating is at the coalface, I've seen some absolutely amazing innovation and delivery of care and some not so great stuff. But I've also seen how the policy and program is developed and some really great stuff. And I think we're at a window of opportunity right now where primary care is in the spotlight. So we just might be able to push through some of the change that's needed if we are able to speak up loudly enough and we don't capitulate.
One of the first lessons I learned in healthcare was we have two conversations, one with the public and the other one happens over dinner with a glass of wine, the Chatham House Rule conversation. Why is that?
Oh, I think that is exactly one of the problems, one of the issues that we hope to confront here. I think the reluctance is that people get squeamish when you talk about healthcare and phenomena like hierarchy, power, interest groups, who controls the story, because that sounds like messy, unseemly political talk. And my hope is to restore the role of politics in all this. There's nothing wrong with talking about politics and policy making. If there's one theme that I think also courses through all of this, it is literally the politics of policy making. And my hope is that if we understand the politics and recognize, look, this is how the world works. It works in every other sector. It works in education. It's at play in where you build a highway or which community gets the next hospital, or are you going to spend more money creating more doctors, or are you going to train more nurse practitioners? These are all, in a perfectly legitimate sense, political decisions. They're not just technical decisions. So that's the truths that I want us to keep exploring, because if you don't understand that that's really what's going on and why a change that seems to be so blindingly obvious, and why, as Ivy said, the same recommendations appear in 55 reports, but they never get done. Instead of throwing up our hands and saying, what the hell is going on here? We need to explain and understand what's going on here, because that's the precondition for doing something about it. Importantly, how do we get the public on side with that? Because if I were to summarize, one of the greatest roadblocks to change is that the interests at play in the system, and there are dozens and dozens, and it's a $400 million a year operation. It is that interest groups will all retail their view of the world as identical with the public interest. I think it's our job in this podcast to try to explore where that's true and where it isn't.
We're talking about where's the gridlock, and I think it does go deep and wide. And having worked as a consultant, I've had glimpses into the parts of the whole, working with federal and provincial ministries, organizations. And again, it's wonderful people doing great things, dedicated, hardworking, but by design, the system has them focusing too much time on protecting their turf. And we've had all of these reports and recommendations about what we need to do, but they're not implemented fully, or we cherry pick them. So what's wrong? Are we Canadians too risk averse to take the plunge? Is it true? Are Canadians too polite? Are we afraid to rock the boat or piss people off? We need to make people a little uncomfortable, and we need to call out when great or even just good ideas are overridden by the political and vested interests.
Ivy, we're on a podcast, so people can't necessarily see reactions, but I saw you having reactions to Dale's comments. I'm just curious about your thoughts then on how do we change that whole idea of public conversations and private conversations.
Absolutely. So I'm going to highlight 2 points because, yeah, I was nodding while both Stephen and Dale were talking. I think that we have this analogy that health policy is a third rail of politics and nobody is going to touch it. And I think that's an enormously dangerous analogy because I think it prevents people from going to places where we need to go. So I think we need a new analogy, and I'm hoping that we can create that in this podcast. The other thing that I want to highlight, a frustration, in addition to accountability and following through, is our seeming inability to spread and scale some really amazing innovative practices. And that seems to be uniquely Canadian. You know, we study other health systems and they're able to spread and scale good ideas and get better results and outcomes than we get here in Canada. And so I'm really curious about having these conversations about what is preventing us from spreading and scaling really excellent care that is accountable, that is safe, that utilizes all the resources that we existingly have in the system without having to add more money. But we have to have some bravery to, I don't want to have people touch the third rail, but we have to have another analogy about how do we move forward and follow through.
I often hear people talk about how the sky is falling. Are we getting to that point? What do you think needs to happen to make meaningful change?
Yeah, I grapple with that issue all the time. And mea culpa, I've used language that, you know, we're on the verge of a breakdown and a crisis and that sort of thing. And, you know, we've been using that language for as long as I've been, you know, in the health policy field. And I think I think people are immune to it now. It is not getting the response that we hope to get from them with that language. I don't know at what point does the frog in the boiling water no longer care that they're in the boiling water. And so I'm not exactly sure. So again, I want to get us back to, yes, this is complex. Yes, this is hard. But you climb a mountain by going one step at a time, and you might slip and fall, but you're still continuing to climb that summit. And we want to encourage people to do that by giving them, you know, the right pathway or being, you know, the people that shepherd them, you know, through a particular route or asking questions of people who could help us uncover what that pathway is and know what the obstacles are so that we can push through the other side and, you know, get better care.
I'm not going to say anything new here, but, you know, it's something that is talked about a lot, but we actually don't do it. So, and we actually, in Canada, we do the opposite. First of all, we've talked about accountability, but we really don't have a framework that lays out goals and expectations about what it is we're trying to do and how to communicate it and then hold people's feet to the fire. At the same time, we squeeze people at the coalface trying to be innovative and trying to achieve those goals when they need greater flexibility. So the term or the lingo is tight, loose, tight. We do the opposite. But what we should be doing is here's what we expect you to achieve. Like no ifs, ands, or buts. Here's the budget. No, I'm not going to be fussy about how you spend your line items or how they're allocated, but just do what's best. Then I'm going to come back and take a look. Have you done it? And I'm going to hold you accountable for achieving those outcomes. And based on those laid out objectives. And like I said, right now in Canada, we do the exact opposite.
We're off the script, right? We're off script here. So, Stephen, maybe I'll throw you a little bit of a curveball here. So, with staying within the theme of meaningful change, you have experience also from Australia. Is there anything in Canada that we could possibly be doing to forward change that maybe you have examples that you've seen in other jurisdictions?
Well, in a way, I think it's almost a stylistic problem. For some reason in Canada, we get very rigid about certain things that we think are great achievements. So we keep beating our breasts over Medicare, and rightly so. I mean, it was a great achievement. It took a lot of guts. I'm not so sure we would ever get Medicare today if we didn't have it, because it took courage, and you didn't stick your finger into the wind and wait for everybody to get on side. It was practically a civil war in Saskatchewan to get it done. And then once you fight the first battle, interestingly, it was pretty peaceful in its adoption across the country, helped mightily by the feds making it a deal that was too difficult to refuse because they put cash on the table. But you mentioned Australia. Australia has a blunter political culture than we do. And the health system is just a feature. Like it's not, nobody says we define Australia because of, they don't even call it Medicare, a public health care. They think, yeah, we should have public health care. By every international comparison, seems to perform better than ours, but they just act, and they act swiftly and decisively, and they will change things when they think they need to change them, and they will have honest conversations. It's not a perfect system, but it seems to work. And when you look at other countries, Northern European countries, or even the best parts of American healthcare, when they decide to do something, the stakes seem a bit lower. They just attempt it. If it doesn't work, they quit doing it. Yes, they make mistakes. Yes, there are unintended consequences. So I think in Canada, we have this strange duality. We're at the same time, as Ivy pointed out, yeah, this system, it isn't collapsing all at once. It's not an earthquake. It's oozing away, and we keep looking away from it. So people pay $5,000 to join a concierge primary care clinic. Is that a violation of Medicare? Certainly violates the spirit of Medicare. Are we doing much about it? No. Are middle class people essentially thinking about buying their way out of the public system, particularly in primary care and long-term care and so forth? It's impossible to buy your way out of the hospital system if you have something serious because it's simply too expensive. Again, if you ask people both on the provider side, the supply side, and the public, nobody gives the system high marks at all. And yet we are incredibly risk averse. The weird part of that is that if you think your system is slipping away on you, it costs too much for what you're getting, it has terrible access problems, it has serious comprehensiveness problems, we don't want to do anything too major to try to fix it. All we will do is get more money, pay docs more money here, maybe train a few more nurse practitioners, and after 10 years, let them practice in independent clinics to look after the 25% of adults who don't have a regular source of care. We don't scale and spread anything. We don't even scale and spread the diagnosis. Like, if there is ever a platform or a condition where people should say, it can't get worse, we should try something big. I mean, how much worse can it be? But we don't. And I think what I hope we do as we move through this series is talk about what have we learned about ourselves, and how do we make it possible to take action without being so fearful about it? What actually are we worried about? And the other thing I would say too, we're going to talk about the usual stuff like the structures and the incentives, the persistence of bad policy, the absence of good policy, and the big one, the lack of translation. We don't have an implementation plan. But I also think we have to talk about the human dimension to this. And we've talked about it briefly already a bit. Courage matters. Do we promote people to leadership positions who actually have the courage to tell some hard truths and to fight some battles?
I want to build on the examples that Dale gave us at the beginning of how things moved forward in South Africa, Stephen's discussion about how they take action in Australia. So I think that looking internationally for inspirations, but there's nothing that's going to be plug and play. We can adapt, not necessarily adopt everything off the shelf. So we ultimately have to look inward about how do we move forward, because have some inspiration internationally, absolutely. But we are going to have to move that through the system. And we're going to need, other elements, in this recipe of moving forward. Courage, absolutely. Accountability, absolutely. And we need the public to understand more about the healthcare system. I think there are certain assumptions that the public have that certain things are happening. I know I had a whole bunch of assumptions about how things were organized around the health workforce, and none of those things were happening. And so I think being better informed and having some fire in your belly to move forward, I think is really important. So that's where I want us to get inspiration internationally, but we're going to have to do this hard work here in Canada through the political structures and health organizations that are here.
Just quickly, I think there's an incredible amount to be learned from international examples. But one of the things that I would suggest is that we always, I've done multiple international comparisons, and we always go to New Zealand, Australia, we look at UK, maybe we throw in a couple other European countries. And we all hear about all these junkets that people go on, lots of money, let's go check out what's happening in Sweden. And then we come back and we really don't do anything new. But sometimes we overlook some countries that are actually doing some really cool things. So we need to cast the net more widely and have higher expectations when we do those comparisons or send people off on those trips. But I think ultimately, as Ivy and Stephen have said, it's really about the leadership back in Canada to sort of say, okay, we're going to do this. This is the information. Let's go full steam ahead. And just a footnote about, does the public really understand our healthcare system? And, what is it that they need to know more to empower them to actually be more vocal and advocate for themselves?
Thanks for listening to Health Policy Off Script. If today's conversation sparked something, an idea, a frustration, or even a bit of hope, then we're doing our job. Canada's health system won't change by accident, but it can change when people stay informed, engaged, and unwilling to settle for the status quo. Join us next time as we keep pushing the conversation from talk to action.